This one, this bacteria is the hottie of the gram negatives, okay, because you have the, it's a she's a hot one, so you remember all the H's, the hemorrhage, the hemolytic syndrome, the hamburger, and also the toxin which inhibits protein synthesis, which is very similar to Shigella. And then another important point is, if you were to grow this bacteria on McConkey's, how will it grow? On McConkey, just McConkey's. Pink or pale, just McConkey's. It's an E. coli, so don't forget, it's an E. coli first. So it will be pink colonies on McConkey's, pink on McConkey's, and pale on sorbitol. Okay? Okay, this is important. So it's pink on McConkey's, it is pale on sorbitol McConkey's agar. So don't miss that one, because the reason why it's grown on sorbitol is because all E. coli's are the same. You don't know whether it is ETEC, EHEC, or EPEC, or any of those. So that's why, because this EHEC is particularly, it produces pale colonies on sorbitol, you use sorbitol McConkey's agar, and only EHEC is pale on this media. Okay, so this is basically what you need to remember about EHEC. So bloody diarrhea and hemolytic uremic syndrome, generally in children following eating mostly these food stuff. Okay, now, so the other E. coli's are not important, so we just stick to these two. And now we will look at the other gram-negative enterobacteriaceae of importance. Let's look at Shigella. Okay, so now if you're looking at Shigella, so this is a gram-negative rod, and on McConkey's it would produce what kind of colonies on McConkey? Pale, because it is a non-lactose fermenter, isn't it? It is a NLF. And it is non-motile, which means it does not possess, it's motility. Non-motile is connected to which? What? No flagella. Yes, there is no flagella. It does not have a flagella. Okay? No motility, no flagella. So it's a non-lactose fermenter, and it also does not produce H2S. These are the three properties of Shigella. To differentiate it, with these two properties you can differentiate it from Salmonella. Yes, and the fact that it is a non-lactose fermenter and its motility will also distinguish it from E. coli. E. coli is a pink lactose fermenter. Okay, so now what kind of infections are caused by, how do you get shigellosis? Now this is one important point you should remember. You see, if you're looking at EHEC, if you're looking at Campylobacter, if you're looking at Salmonella, you get this infection from animal products, isn't it? All of them. You can get it from poultry, meat, milk products, but shigellosis has no animal reservoir. So shigellosis is always from person to person. Shigella infection is always from person to person. Human beings are the reservoir. Okay, so you would ideally see this infection in what setting? Child care. Yes, usually child care, aged, home for the aged. There's a reason why you get these infections mostly in this, because children and the elderly, it's difficult to maintain hygiene. So any intestinal infection easily is transmitted from person to person, typically in this setting. What is the infectious dose of Shigella? It's very low, less than 100. Okay, so this is another important factor, infectious dose and its resistance to acid, which means that when it passes through the stomach, it can resist the acid. So you need, see, if 100 bacteria is, swallowed, 10 can survive and cause infection, you see, because the infective dose is very low. Okay, small number of bacteria is enough to cause infection. So these are some of the most important points about the infection of Shigella, which is often tested, the infectious dose. Next, What is the main pathogenesis of Shigella? What kind of diarrhea or what kind of infection does it cause? Blood and blood, more than blood, yes, you will see three things. Okay, mucus. In fact, there is hardly any fecal material. Mucus, second, lots and lots of polymorphs, pus cells in this stool, and three, blood streaked. So these are the three. Usually the patient will complain of tenesmus because of the irritation, and also 10 to 15 times he passes, he wants to go to the restroom, and then all that he would say is, I'm just passing some mucus and blood. Okay, so this is typical of Shigella. It starts off as a bloody diarrhea, but it gradually turns to blood and mucus. So this is always emphasized, numerous polymorphs in the stool and blood. Why do you see so many polymorphs? Because Shigella infection, there is lateral invasion of the bacteria, isn't it? It invades the mucosa, and then it invades the mucosa sideways, lateral invasion, giving rise to ulcers. Okay, so that's why, that's why you see, that is why you see blood, mucus and polymorphs. This is one of the bacteria which can invade the mucosa and give rise to shallow ulcers. So this is in a nutshell what you need to remember about Shigella. The fact that it produces a toxin is not that, it's not such an important virulence factor, because there is only one strain of Shigella which produces the toxin. Not all strains of Shigella produce the toxin. The major virulence factor is lateral invasion of the mucosa, and that's why you see a lot of polymorphs in blood. Typically, less of fecal material, and tenesmus. Tenesmus mainly because of the irritation of the mucosa. Okay, so how to differentiate it from E. coli? It's very clear. This is a non-lactose fermenting bacteria. E. coli is motile and lactose fermenting. This is non-lactose fermenting, and it produces H2S. And its pathogenesis is very distinctive. There is no confusion about this with. Okay, is that clear? Okay, then let's look at Salmonella. Now Salmonella, its nomenclature is a little confusing, but all species, there's only one species, Salmonella enterica, and then of course there are many other serotypes. We don't worry about any one of them. Broadly, Salmonella is classified into the typhoidal and the non-typhoidal. Okay, now the typhoidal Salmonella are very rare in the US, very rare in the US, but because it's a serious infection, you should just know something about typhoidal Salmonella. One important feature about this bacteria is that it mostly presents as more like, not so much as a gastrointestinal infection, it manifests more like a septic, the bacteria is seen in the blood. Okay, so one feature of that is this, and the second feature that you should remember is it can remain latent in the gallbladder. Chronic carrier state, and third, infection is always from person to person, like Shigella. There are no animal reservoirs for Salmonella typhi. Typhoid, if there is a case of typhoid, you know that that person got it from another human being, not from any animal resources. Okay, now let's look at non-typhoidal Salmonella. Non-typhoidal Salmonella, how do you get this infection? Yes, from animal products, poultry, meat, poultry, and turtles, yes, reptiles. Yeah. Okay, so these can contaminate food or food products, and you can get Salmonella infection. So that's one major difference between typhoid and non-typhoidal Salmonella. Okay, here there are no animal contact or no animal reservoirs, whereas there is animal reservoirs. What's the most common infection seen in the US caused by non-typhoidal Salmonella? gastroenteritis. Gastroenteritis because food, poultry, eggs, or any food products. So gastroenteritis being common, if someone who has sickle cell disease is infected with the non-typhoidal salmonella, he runs the risk of osteomyelitis. Okay, the reason why it is associated with sickle cell disease is because, again, if the person gets gastroenteritis with salmonella, the salmonella can enter the bloodstream and then it can give rise to osteomyelitis because the capillaries are blocked by sickle cell disease, and so the bacteria can go and latch onto these, the RBCs which are blocking the capillaries. That's the reason why it mostly causes osteomyelitis. Okay, so salmonella gastroenteritis and osteomyelitis in sickle cell disease. Okay, so what are the characteristics of salmonella? It's a non-lactose fermenter. Non-lactose fermenter. It is motile and it produces H2S. H2S. 1, 2, 3. These are the 3 characteristics. Okay, so gastroenteritis in a case, and this gastroenteritis, is there blood? Yes, it is. There is blood in the stool. Many cases of salmonella gastroenteritis can present with blood, fever. It's an inflammatory diarrhea, and also it's a non-lactose fermenting bacteria. It is motile and it produces H2S. Okay, sorry, I should have this should come here. So NLF, motile, and H2S producing bacteria. So that's all about the non-typhoidal salmonella, its association with gastroenteritis and sickle cell disease. Then other enteric bacteria, since we were dealing with E. coli, EHEC, the other enteric bacteria is Campylobacter. Now Campylobacter, very distinctive morphology, spiral, gull-wing shaped. Then what are the other, what do you think would be the clues for identifying Campylobacter? 42 degrees Celsius and microaerophilic, and anything else? These are the 2 most commonly given characteristics. 42 degrees is its optimum temperature, and the fact that it is microaerophilic, and the fact that it is a spiral bacteria. Okay, these 3 characteristics are distinct. See, when they give you 40, say for example, they give you a case of someone with diarrhea with blood in the stool. So you will think of salmonella, you will think of Shigella, you could think of Campylobacter. Okay, you could also think of Vibrio parahemolyticus. But if you think carefully, all 4 of them are very distinctive. Salmonella would be NLF, H2S producing gram-negative rod. Campylobacter would be spiral, 42 degrees, and microaerophilic. Okay, EHEC would be sorbitol mecconchi, gram-negative rod, isn't it? And hemolytic uremic syndrome. Vibrio parahemolyticus would be a salt-tolerant bacteria, curved rod. You see, so these clues will be there. Otherwise, you cannot differentiate. And also, how do you get Vibrio parahemolyticus? What's a food source? Seafood, isn't it? So these differential clues will be provided. Maybe one of them, not all of them. So you can easily distinguish between these bacteria. If you may not get all the clues, but at least one. Okay, and that. So just know these. They are very, very distinctive. No confusion. So Campylobacter, what are the food? Poultry, meat, milk, because again, because of contamination with cattle, and puppies and kitten. Yes. Pet, cat, of course. Okay, so these are the sources from where you could get Campylobacter. Again, in Campylobacter also you will see blood in the stool, and to some extent it is an invasive. It can also invade, but it's not as invasive as Shigella. Okay, so that's about Campylobacter, straightforward. And you know the sequelae is, yeah, what's the sequelae? Post-infectious sequelae of Campylobacter? Guillain-Barré syndrome. Yes, it is also associated with, yeah. Okay. Then the enteric gram-negative, Yersinia enterocolitica. Yes, Yersinia enterocolitica. Yersinia, what is typical of Yersinia? It's also a gram-negative rod, and one of the distinctive feature of this infection is that what is one of the complications that you can see in Yersinia enterocolitica? Mesenteric adenitis, pseudoappendicitis. Okay, many infections of Yersinia are associated with pseudoappendicitis or mesenteric adenitis. That's all what they normally ask about Yersinia enterocolitica, if at all they ask. Okay, because it's not very common in the US, so we don't see too many questions on Yersinia enterocolitica. Okay, so then, yes, anything else that I've left out in the enteric? Pseudoappendicitis, mesenteric adenitis. Mesenteric adenitis, because of the adenitis, it presents many times. It's mistaken for appendicitis. It can present very similar to appendicitis. Okay, pardon me? No, Yersinia pestis is a zoonotic infection. We are not dealing with that now. Okay, so then I think I forgot listeria. Somebody pointed it out to me, isn't it? Listeria. Yes, listeria is important. So let me just tell you about listeria. What's the morphology of listeria? Gram-positive, cocobacilli, yeah, or rods. Okay, one. Second, any other distinguishing feature, clues? Tumbling motility. 4 degrees Celsius, cold. It can multiply abundantly in the cold. Okay. Then, on blood agar, beta hemolysis. Yes, catalase positive. Okay. So these are some of the characteristics of listeria. Now, what are the virulence factors? Listeriolysin, O, then internalin, and 3, the actin filaments, the rocket. Okay, so you see, and listeriolysin O, you just remember the O, it can escape from the phagocyte using this toxin, you see. So from the phagocytic endosome, it escapes using listeriolysin. Internalin, it helps it to attachment to the host, and actin filaments, it can move from cell to cell. These are the 3 important virulence factors of the listeria. Okay, then how do you get listeriosis? Mainly from cheese, milk products, meat. Okay, then what kind of infection does it cause in an immunocompetent individual? Immunocompetent individual, a flu-like illness, nothing to worry about. But suppose, say for example, a pregnant woman is infected with listeria. What is the major risk? It can cross the placenta. And what is the disease? What's the disease? Granulomatous infection. Okay, so in a newborn, when it crosses the placenta, it gives rise to a granulomatous infection. Then it can also give rise to meningitis, which is generally seen less than 1 week or beyond 1 week. Okay, so granulomata infantaseptica, granulomatous infection in a newborn is highly suggestive of listeria. What is the third category of people? With depressed cell-mediated immunity, as in HIV patients, it can give rise to meningitis. Okay. So granulomatous infection, meningitis, neonatal meningitis, this is neonatal meningitis, and HIV patients, it can give rise to meningitis. These are the main infections caused by listeria. Okay, so the characteristics of listeria are very, very distinctive. So you will probably get a clue, and or don't forget that it is a gram-positive coccobacilli. Okay. So then next we have a few gram-negative rods like Pseudomonas. So Pseudomonas, gram-negative rod. What else? Oxidase positive. Then you have the fruity odor, musty odor. All those are characteristics. So the green pigment, gram-negative rod, oxidase positive, the fruity odor, musty odor, metallic sheen. These are all characteristics of Pseudomonas. What are the virulence factors? Yes. Alginate, yes. Capsule, alginate, then exotoxin A, good. Then endotoxin, yes, good. Then elastase, yes, elastase. Anything else? Okay, phospholipase. Okay, now let us look at the infections that are associated with mainly with these virulence factor. So, alginate producing strains. Which infection? Cystic fibrosis, yes. So they could give you a case of cystic fibrosis. They could give you a few classical symptoms of cystic fibrosis and ask you which, they could say probably a gram-negative rod was isolated from the secretions. Which of the following virulence factor is playing an important role? Okay. Now, exotoxin A, what is its action? EF2. Very similar to diphtheria, just like diphtheria, okay, don't forget. So it inhibits protein synthesis. It is similar to diphtheria. Exotoxin A, what are the infections? One is ecthyma gangrenosum. What is ecthyma gangrenosum? Gangrenosum, yes, skin lesions. This is seen in skin lesions in leukemic patients, neutropenic patients, okay. Oof, sorry. So neutropenic patients, you see ecthyma gangrenosum, and one of the important virulence factors is exotoxin A and also endotoxin. These two, both these can play an important role in ecthyma gangrenosum, okay. Then malignant otitis externa. Ear infection, external ear infection in diabetics. There is necrosis and also damage to the tissue, necrosis and osteomyelitis. What are the virulence factors? Elastase and exotoxin A. Okay, so there is tissue damage. There is extensive tissue damage, so elastase and exotoxin A. Okay, these are the two major virulence factors. So we were just looking at a few important infections of Pseudomonas. Ecthyma gangrenosum in neutropenic patients, which can present as a sepsis and skin lesion. Then cystic fibrosis with alginate producing strains. Otitis externa, which is mostly seen in diabetic patients, severe malignant otitis externa. Again, exotoxin A and elastase. Because remember, enzymes like elastase and phospholipase play an important role in skin manifestation, tissue. Okay. Then other infections like UTI, hot tub folliculitis, these are all minor infections, but these are the major infections that they normally ask, that is ecthyma gangrenosum, cystic fibrosis and malignant otitis externa. Okay, so that's about the Pseudomonas, its characteristics, identifying features and virulence factors. Okay, then we forgot about Proteus. Proteus, what are the characteristics of Proteus? Yes, one is urease producing bacteria. It's a gram-negative rod. It's non-lactose fermenter, and it also produces. It's motile. Anything about its motility? Swarming. Yes, it just spreads. It just spreads and swarms everywhere. So urease. What's the infection that you normally associate? UTI. Yes, UTI with stones. Staghorn. Yes. Staghorn calculi. And what's it made up of? Magnesium ammonium phosphate. Okay. So that's about protease. Very distinctive. Staghorn calculi, magnesium ammonium phosphate, and because it produces the enzyme urease, it can cause the urine to become alkaline and precipitate the stones. Okay. Then we're looking at Vibrio. Next, Vibrio. Now in Vibrio, it's a gram-negative comma-shaped bacteria. Gram-negative, oxidase positive, motile, and one important characteristic is that it can tolerate salt. Okay, that's why it is a marine bacteria. Tolerate salt, so it's mainly a marine bacteria. So Vibrio cholerae, two important aspects which are tested. One is its sensitivity to acid. It's quite sensitive to acid, gastric acid. Therefore, you need a high, it's got a high infective dose. That means you need a lot of bacteria. Okay, a lot of bacteria to cause infection. When does this become low? In someone who is, yes, achlorhydria. Okay, or somebody who's taking antacids. So in such individuals, the infective dose can become, you need a smaller number of bacteria can cause infection. Okay, so these are the two concepts that they normally test. And then of course, what they always would love to ask is the action of the cholera toxin, that all of you know, isn't it? Cyclic AMP, yes, elevation. So it stimulates the GS phosphorylation of adenyl cyclase and elevation of cyclic AMP, and it mainly binds to the, it's a stimulatory GS protein. I mean, it binds to this and stimulates. So that's about the Vibrio cholerae. Okay, Parahemolyticus and Vulnificus. Para and Vulnificus. Okay, they both have lot of similarities in the sense both of them are Vibrio, both of them are salt tolerant. Yes. See what I have seen, this is not of course for the mini, I'm not going to test you, but in the comp, yes, they do, because there is another cyclic AMP toxin, that is the pertussis toxin, that is GI, and this is cyclic AMP elevation binding to GS. So that they ask, that is more of an integrated like cell biology, all that together. In that context, yes, you need to know. Okay. So in Parahemolyticus and Vulnificus, both of them are Vibrio gram-negative, same characteristic. The only difference is this usually causes diarrhea with blood. This also can cause blood and diarrhea, but in this it also gives rise to a severe sepsis with bullous lesions. Bullous skin lesions. Okay, so you can get Vulnificus infection even when swimming. It's common among divers. Okay, and the other main feature about this is iron. You know, people who have alcoholics as well as those who have iron not deficiency, who have what is that, Iron overload, yes. Diseases, they are more prone to Vibrio vulnificus infections. Okay, so you get this infection. Both these infections are mostly from, yes, you know, marine, you know, seafood mainly. Yeah, but this one, this vulnificus infection is characterized mainly by severe sepsis, and this is much more fatal than parahemolyticus infection. Okay, so that's about the gram-negative curved rods. So I think we are done with all the, any other gram-negative? I can't think of it. Oh yes, Helicobacter. Helicobacter pylori, the curved bacteria, you know, its association with gastric ulcer. Helico. What are the other virulence factors? Urease, VAC-A, and CAG. Okay, these are the main virulence factors of Helicobacter pylori. What they normally test you is the invasive and non-invasive test. What's the invasive test? Both of them are testing for urease production. The non-invasive, invasive test is, yeah, biopsy agar. Okay, you take the biopsy and put it into an agar which has urea, and it will give a positive test. And non-invasive, yes, the urea breath test. Yeah, C13. You take a urea meal. That's normally in micro. That's the maximum, that because this is more tested in path. Okay. So Helicobacter pylori, a urea breath test, and an invasive and non-invasive test. That's all what you need to know. Then next, yes, we have to look at Bordetella pertussis. Pertussis, what is pertussis? It is a gram negative. Okay, it's a gram negative coccobacilli. Then, what are the virulence factors? Okay, what does pertussis cause? What does it cause? Whooping, yes. The characteristic whooping, paroxysmal coughing. So, why the paroxysmal coughing? The virulence factor associated paroxysmal continuous cough. Why? Yes. Common sense kills the cilia. Cilia is completely destroyed. So what are the virulence factor that does this? One is filamentous heme agglutinin. The bacteria adheres to cilia using filamentous heme agglutinin. Then tracheal cytotoxin. Third, adenyl cyclase, and another toxin, pertussis toxin. What does it do? Yes, it causes elevation of cyclic AMP. Not only that, 2, lymphocytosis. Why? You see lots of lymphocytes in the peripheral blood. Why? Because it inhibits chemotaxis. You see, when during Bordetella pertussis infection, lot of lymphocytes are generated. They cannot migrate to the site of infection. They stay in the blood. So it inhibits chemotaxis. The pertussis toxin causes elevation of cyclic AMP, tracheal cytotoxin, and filamentous heme agglutinin. These two, they together destroy the cilia. That's why you see the paroxysmal coughing. Before the cough starts, what is seen? What is preceding the cough? You see a severe rhinitis. The rhinitis is partly because of the cyclic AMP. For, you know, severe rhinitis. How do adults present with pertussis? It's now common in the US. Do adults also have paroxysmal coughing? No. But, okay, adults can present with cough, but it's not a paroxysmal coughing. Adults present with rhinitis and cough cough for about, yes, more than 3 months. The cough can last for more than 3 months. Okay? But the paroxysmal coughing, which is typically seen, the whooping cough, is generally not seen in the adults. Okay? So pertussis, the virulence factors are important. Filamentous hemagglutinin, tracheal cytotoxin, adenyl cyclase, pertussis toxin, which causes elevation of cyclic AMP. Then, how do you grow pertussis? Bordetella pertussis. What's the media? What's the method? The cough plate method, using which media? Bordet jungo, isn't it? And the Regan lovely medium. Yes. So Bordet jungo or Regan love medium, and the, yes. So that's about the pertussis. Mainly the virulence factor, typical, and the symptoms are so classical. They give you the classical symptoms of pertussis. Okay. Then Hib. What is the most important virulence factor of Haemophilus influenzae type B? The capsule. And what is there in the capsule? The PRP, the phosphoribosyl phosphate. That is what makes the B so virulent. The Haemophilus B makes it virulent because of the PRP. The other Haemophilus influenzae, they don't have this PRP in their capsule. That's why they are not that virulent. What's the morphology of Hib? Pleomorphic, gram-negative, coccobacilli. Okay. How do you grow Haemophilus influenzae? Yes, on the chocolate agar. Chocolate agar. Why? This is lysed RBC. Chocolate agar is made up of lysed RBCs. So the lysed RBCs will release two important growth factor which is required by Haemophilus. Which are they? The X and V factor, that is hemin and NAD. Yes, hemin and NAD. Okay. So this in a gist is what you should remember about Haemophilus influenzae. Hib, the conjugate vaccine, of course, like polysaccharide pneumococcal vaccine, you have the conjugate vaccine. Okay. Now, those strains without a capsule, the non-typable Haemophilus influenzae, is now becoming important in the US as a cause of, what are the infections caused by Haemophilus influenzae? Non-typable strains. Otitis media, yes. Otitis media, and sometimes it also causes pneumonia in the elderly, but mainly otitis media. Okay. So Hib is rare, but they still test you on this bacteria. Okay, Hib, especially the capsule, the PRP capsule. Then the Legionella. So, can you visualize it in the gram stain? What's a clue for? Yeah, first of all, remember when they say, okay, so how does Legionella, what are the symptoms? Okay, it's a pneumonia. So, it's a pneumonia. What is distinctive? So, a person with pneumonia would definitely present with respiratory symptoms of cough, fever. Yeah, mostly, yes. Non-productive cough. And so symptoms of pneumonia, non-productive cough, mental confusion, and diarrhea. Okay. These are distinctive features of, so pneumonia. And what is the age group? Usually who gets? The elderly, especially elderly male. Anything else? Smoker, alcohol. Okay. So these are, in Legionella typically is mostly seen in an elderly male who has been a chronic smoker who's an alcoholic, and then they're present with pneumonia, non-productive cough, mostly non-productive, mental confusion and diarrhea, highly suggestive of legionellosis. Okay, then what is the source? Water, isn't it? Fresh water. So it could be exposure to aerosols. So sometimes they may not give, when they give you all these classical symptoms, they may not give you any exposure to water sources. Sometimes they might give you a clue as a exposure to water sources. So these are the classical symptoms. Now, important things to remember, it does not show up on a gram stain. Okay, so you have a case of pneumonia and they say that no microorganisms were seen in the gram stain. What's the alternative? Silver stain. Okay, so silver stain. What is the media used for growing listeria? Oh, sorry, Legionella? Buffered charcoal, yeast extract agar, or it is a media that is supplemented with cysteine. Okay, so this in a nutshell is all about Legionella that you need to remember. Okay, so the fact that it does not show up on a gram stain, so it's demonstrated by silver stain, and you see a pneumonia in an elderly male, mostly male alcoholic smoker. Okay, then what is the virulence factor? Does it produce any toxin? Inhibition of phagosome, lysosome. This is the main virulence factor of Legionella. Okay? Yes, inhibition of phagosome lysosomal fusion. It can stay, the Legionella can also stay inside a phagosome like Mycobacterium. That's the reason why beta-lactam drugs are not that effective against Legionella. Okay? Phagosome and lysosome, they have to fuse since the virulence factor is a protein which inhibits phagosome lysosomal fusion. Yeah, the virulence factor is that it's able to inhibit phagosome lysosome fusion. Okay, just like Mycobacterium. So that is Legionella. So yeah. So in that category of Bordetella, Haemophilus, Legionella, we are done with that. Then we look at Mycobacterium tuberculosis, MTB. Okay. So what are the characteristics of the most distinctive characteristics? If it has any distinctive characteristic, you should know about it. Does it show up on a gram stain? No. No gram stain. Then what's the stain that is used? The acid fast stain. Okay, so why? Why? Because it has mycolic acid, or what is it also known as? Trehalose mycolate. Okay, yes. What is the virulence factor of Mycobacterium tuberculosis? One is, of course, the mycolic acid. Two, the cod factor, which is same. The cod factor is also trehalose mycolate. Then sulfatides. And fourth, it can inhibit phagosome lysosome fusion. Okay, this is the main virulence factor of Mycobacterium tuberculosis. So the cell wall characteristics, the mycolic acid, because of that you can't stain the bacteria. It is you can't use many antibiotics, many of the common antibiotics to treat Mycobacterium main tuberculosis infection, mainly because of this mycolic acid, which is a waxy substance. Okay, so that's about the characteristics of Mycobacterium. How long does it take for this bacteria to grow? It's 8 weeks. It's a slow growing bacteria. Okay, now how will you what is the classical symptoms of tuberculosis? Typically in the US, it's rare. So how do you get tuberculosis? Again, it's a bacteria which is transmitted from person to person. No Of course, you can get tuberculosis from cattle, but that's very, very rare in the US. So it's a person-to-person transmission. Okay. So typically, most of the cases will talk about a prison inmate or someone who is, a homeless individual or an HIV person, HIV patient. Okay. These are common settings where you get tuberculosis, or the scenarios where they give you a case of tuberculosis in the United States. What are the classical symptoms of TB? Cough. Yes. Chronic cough, productive, chronic cough, night sweats, then weight loss, and hemoptysis. So this is a classical symptoms of tuberculosis, where a person has fever, night sweats, especially evening rise of temperature, and has a weight loss and productive cough with blood, usually blood in the sputum. Okay. So primary infection is characterized by, what's a gone focus? Gone focus? You see the hilar? Yes, hilar lymph nodes and the primary lesion together is called the gone focus. In reactivation of tuberculosis, where will you normally see the lesions? Reactivation. Apex, yes. Oxygenated regions, apex, usually the reactivation, you see it in the apex of the lungs. The reason is because Mycobacterium tuberculosis is a, yes, oxidative. It's not an anaerobe, sorry, it's an aerobe. It's an aerobic bacteria. Okay. So that is about MTB, the most important features. Then Neisseria. Hey, what's happening? Are the mycobacteria? No. Good you asked, yes. Thank him. Oh, what's happening? Okay. So, no, Mycobacterium leprae, we are not testing you on this mini. Yes. Because you have enough. Oh, okay, Klebsiella, yes. Thank you for reminding me. Klebsiella, what is it? It's a gram-negative rod and very prominent capsule. So on McConkey's medium, pink colonies. What does it normally cause? Klebsiella. Yeah, lung abscess, aspiration pneumonia, mostly in, when you see aspiration pneumonia, what is the alcoholics? Yes. What's typical of the sputum? See, red, currant jelly, yes, sputum. Okay, so that's about Klebsiella. Okay, then we have another very important bacteria, that is Neisseria. Neisseria, what is it? Gram negative cocci. Okay, 1, 2, oxidase positive. Gram negative cocci, diplococci. Gram negative diplococci, oxidase positive. So we are first looking at Neisseria meningitidis. Does this have a capsule? Yes. That's why you have a vaccine. Meningococcal vaccine that is made up of the capsule. So, what is the infection caused by Neisseria meningitidis? What is the most common infection caused? Meningitis, community acquired meningitis. Okay, this is the most common cause of meningitis, especially in children, and young people. Why? Because it's exactly because of the epidemiology. This is a bacterial infection you can acquire from person to person. So that's why typically they will always give a case of an adolescent or a college student who is living in a dormitory. Okay, so just casual. See, even if you just sit next to a person, that sometimes may not be, the how you contract the infection. But if you've been a roommate or if you've been, in close touch with a person, you could probably get the Neisseria meningitis. So the important point is, this is a meningitis which is transmitted from person to person. So it's a community acquired. You can get, it's a transmissible infection. Okay. So how does this meningitis, apart from meningitis, it can also cause meningococcemia or a severe septicemia. Okay. Now, what is the most important virulence factor? One, of course, is a capsule, and the other, the endotoxin. Okay, which is also, what is special about the endotoxin of Neisseria meningitis? It's also called a lipo-oligosaccharide. Okay, it's a very potent endotoxin, and so the so somebody who is infected with this bacteria, how will they present? Yes, the endotoxic shock and also purpura, petechiae, skin. Typically, you will see the sudden onset of fever, stiff neck, and the sepsis will present with purplish purpura, petechiae. That is typical of Neisseria meningitis. Okay, so remember the epidemiology, the typical setting, the most important virulence factor is endotoxin, then of course the capsule, and the other characteristics, that it is gram-negative cocci and it is oxidase positive, meningitis and septicemia. Okay, then gonorrhea, gram-negative cocci, oxidase positive. Does it have a capsule? No capsule. And ferments glucose. Okay, so then the virulence factor, gram-negative diplococci, what are the virulence factors? Pili, yes, don't forget the pili. Okay, then the porins, the OPA, yes, the OMP and the OPA, opacity factor. Okay, so then of course it also has the endotoxin because it's a gram-negative bacteria. Okay, so pili, what is the importance of pili? It's for attachment, and what does it do? What else? Antigenic variation. It keeps changing the pili protein. So antigenic variation in gonococcal infection, very, very important. Pili keeps changing the pili protein, so recurrent infections and the ability to keep infecting the epithelial cells. It also produces IgA protease. Okay. Now, gonococcal infection typically presents, it's a cervicitis. You see a purulent discharge. You can demonstrate the bacteria in the gram stain. Typical, there are no ulcers or ulcerative lesion. It is just a purulent discharge. It's a cervicitis or urethritis. That is a typical presentation of gonorrhea. Now, what is the major complication of gonorrhea in females? Pelvic inflammatory, PID, pelvic inflammatory disease, and disseminated gonococcal infection. So disseminated gonococcal infection, what are the manifestation? Gonococcal infection, is it a cervical infection or a vaginal infection? It infects the cells of the cervix. It does not infect the vaginal epithelial cells. Gonococcus in pubertal females infects only the cervical. In pre-pubertal, yes, it can infect the vaginal epithelial cell, but it's an infection of the cervix. So disseminated gonococcal infection is very, very important. It presents as cervicitis, arthritis, and skin lesions, pustules. This is one of the complications: pelvic inflammatory disease and disseminated gonococcal infection. Cervicitis, arthritis, and skin lesions. In fact, in the United States, DGI is a more common manifestation. So, patient will complain of joint pain, especially the large joints, and they will present with skin lesions, and also, if it's a female patient, they will also present with cervicitis. Okay. Now, what is the media used for growing gonococci? The Thea Martin medium. What is so special about Thea Martin? It is it's a chocolate agar which is made selective with antibiotics. It's a selective medium. You need a selective medium to grow gonococci. Okay? Yeah. So, what is the drug of choice for treating gonococci? No. What is the drug of choice for treating gonorrhea? Ceftriaxone. One shot of ceftriaxone. Now the problem is you cannot use ceftriaxone to treat chlamydia. Because why? Why? Why is this antibiotic ineffective? Sorry. Because chlamydia. What is this? What's the category of ceftriaxone? What category of antibiotic is it? It's a cell wall acting antibiotic. So what is its target? What component of the cell wall? The peptidoglycan. Does chlamydia have peptidoglycan? No. So you cannot use this antibiotic to destroy chlamydia. So the alternative is you can use either azithromycin or doxycycline. Okay. Now, when you have a case of a patient, even in the United States or anywhere in the world, they come with you with the symptoms of cervicitis. You don't know whether it is gonococcus or chlamydia. In many cases, both are present. Therefore, you will give the patient ceftriaxone and azithromycin or doxycycline. It is azithro or doxy. One of the two. That depends. That doesn't matter. But ceftriaxone and azithro or doxy. Okay? So that's about the disseminated gonococcal infection. And so you can recognize gram-negative cocci within pus cells in a specimen of gonorrhea infection. Okay? Then, so gonococcus and meningococcus, that's what you need to know. Then you have the chlamydia. So let's just look at chlamydia right now since we are talking about chlamydia. So chlamydia, what are the characteristics of chlamydia? What is it? It's a intracellular. Yes. You can't forget this. Then 2, obligate. It cannot live outside a cell. 2, yes. ATP, it needs host ATP. Okay? Don't forget that. And no peptidoglycan. Yes. So, or peptidoglycan is also called muramic acid. Then 4, no gram stain. Obviously because does not have any. Okay. These characteristics of chlamydia are very, very, very important. What are the 2 forms in which it exists? Elementary body and reticulate body. Which is the infective form? Elementary body is the infective form. Okay? Reticulate body is what you see inside when it's multiplied. Okay, so the characteristics of chlamydia is very, very important. This is the reason why you can't use any cell wall acting antibiotics to treat chlamydia. Manifestation of chlamydia is it usually does not give rise to such a purulent discharge cervicitis as you see in gonococcus, but clinically sometimes it's very difficult to distinguish whether it's chronic gonococcal infection or chlamydial infection. Urethritis, cervicitis, just like gonococcus. So what are the alternate, how do you demonstrate chlamydia if you cannot gram stain it? Iodine, Giemsa, or immunofluorescence. Okay, immunofluorescence. Now, a woman who is infected with gonorrhea or with chlamydia, what are the risks for the newborn? Conjunctivitis, ophthalmia neonatorum. So because this bacteria infects the epithelial cells, and gonococcus also infects the epithelial cells, the newborn can become blind. The bacteria, if it infects the eye, it can destroy the eye and cause blindness. Okay, so ophthalmia neonatorum is another complication of chlamydia. Now, what is inclusion conjunctivitis? Inclusion conjunctivitis. What are these chlamydia called when they are seen inside the epithelial cells? They're called inclusion bodies, isn't it? Chlamydia, when it's seen inside the epithelial cells, they're called inclusion bodies. Inclusion conjunctivitis is infection caused by chlamydia, chlamydia trachomatis. Okay, what does chlamydia psittaci cause? Chlamydophila psittaci. Psittaci. Yes. It is usually, it's a pneumonia that is seen in bird handlers, psittacosis, parakeets and birds. Okay. So, chlamydia, yeah. It's yes, you have to know, very simple, what is the incubation period for gonococcal infection, gonorrhea? 48 hours. Okay, generally average 48 hours. So less than 5 days for gonorrhea, greater than 5 days for chlamydia. The rule is usually less than 5 days, for gonorrhea. Because gonorrhea, remember, has a very short incubation period, usually 48 hours. Okay, so we are done with all the chlamydia. Then you have syphilis and the spirochetes. Yes, that was done some time back, isn't it? Syphilis. Okay, so quickly, the syphilis and leptospira, because these are such important bacteria, you can't. Okay, so what are the characteristics? It's a spirochete, Treponema pallidum. We are looking at Treponema pallidum. It's a spirochete, and does it show up on a gram stain? No. How do you demonstrate? Dark ground microscopy, or the silver stain. Okay, yes. So what are the virulence factors of treponema? Does it have any toxin? Then how does it cause so much damage? It produces hyaluronidase, and so it can spread within the tissue. Okay, so primary syphilis, how will you recognize? What's a typical feature of, okay, primary syphilis, painless chancre. Yes, so primary syphilis, painless chancre, in duration, it's a chancre, hard chancre. Okay, now what is important for you to know is what are the diagnostic tests for primary syphilis? One, yes, VDRL, and where do you see the lesion? Where do you normally see the painless chancre? It is seen on the mucosa. Wherever wherever the microbe has entered the tissue. It could be in the genital tract, it could be in the oral cavity. Typically you see these lesions on the mucosal membrane. Are these lesions infective? They are highly infective because these lesions, these chancres are teeming with bacteria. You will see millions of spirochetes in these lesions. Okay, therefore dark ground microscopy is a useful technique for primary syphilis. From the chancre you can demonstrate the spirochetes by dark ground microscopy. Okay, now the question that is often asked is, what are you testing in VDRL test? What are you testing? What type of antibodies? Non-specific antibodies. So it's a good screening test. How will you confirm? FDA ABS. Okay, this is a what type of antibodies? What type of, is it non-specific or specific? These are specific treponemal antibodies. Okay, so VDRL is non-specific and FDA ABS is a specific antibody test. Anybody who is positive by VDRL should be confirmed by the FDA ABS. But you should never do the FDA ABS first. Every person suspected of syphilis should first be screened by VDRL test. Okay, what is the value of, how do you, what VDRL test is useful? Now you're treating a patient. Which titer is useful, VDRL or FDA ABS? Okay, so one point which you should remember is these non-specific antibodies will disappear with treatment. Okay, what are these antibodies produced against? Non-specific antibodies? That is mostly out of tissue damage. Tissue damage causes these non-specific antibodies, so they will disappear with treatment. That's how you know whether the person has responded to the antibiotics or not. Whereas these specific antibodies, they will, do you know what they say about the specific antibodies? Indelible mark of sin. Because these antibodies will never disappear. Lifelong, sin, indelible mark of sin. If you have sinned, yes, if you have sinned, if you have committed a sin, then the treponema pallidum antibodies will never disappear. You will always know, okay, your past, it's a horrible past, yes. Yeah, so the specific antibodies, they don't disappear, they stay on, whereas the VDRL antibodies, they will disappear with treatment. Okay, so this is an important point which you should remember. Now, this is primary syphilis. Secondary syphilis also the same tests are useful. Okay, you have to do the VDRL test, confirm with FDA ABS, and you can also perform a dark ground microscopy. Okay, what is the manifestation of secondary syphilis? Yeah, no, what is the manifestation? Flu-like symptoms and rash. You know, the coppery maculopapular rash, which is also seen on the palm and soles. So you can typically see that in secondary syphilis. Now, tertiary syphilis. Tertiary syphilis would be, yes, tabes dorsalis and Argyll-Robertson pupil. So tertiary syphilis, generally the person is not infectious. It's more of a immune mechanism. So tabes, so you have generally an elderly, because tertiary syphilis is a long-term manifestation of syphilis. So tabes and Argyll-Robertson pupil, yes. That's about leptospira. Leptospira, how do you get leptospirosis? Urine, yes. And what are the manifestation? Jaundice and conjunctival suffusion, yes. So then Lyme disease easy. Okay, I don't think I need to go. Okay, only one thing I would like to ask: what is the best lab diagnostic test for Lyme disease? Hmm? How will you confirm? Lyme disease is common in the US. You have okay, somebody is presenting with okay, the bullseye rash is okay. Bullseye rash is often missed. You could do now. What is important is you can't easily demonstrate the spirochete like how by dark ground microscopy. Okay, in Lyme disease. So microscopy is not a good option. Culture is not a good option. So you're left with ELISA and Western blot. But ELISA, first choice. Western blot is mostly a confirmatory test. Okay, so ELISA is the preferred diagnostic test in Lyme disease. They could give you both the options, and you need to choose. Go for ELISA. ELISA is good enough. Yes, yeah. Don't worry about Western blot. First ELISA. Because you can never choose Western blot over ELISA. Okay, that is for confirmation. If they ask you what is the diagnostic, first you screen it with ELISA, and that's I guess that's then the those others like what you say, the zoonotic diseases, they are all pretty straightforward. Okay, so Yersinia pestis, and what's the other one? Bartonella. Which are the other zoonotic? Francisella. Rickettsia. Okay, rickettsial infection, Rocky Mountain spotted fever. That's the most common one. What's the typical presentation of Rocky Mountain spotted fever? You see the rash, petechial rash usually starts from the ankle and wrist and spreads inwards. What is the vector? Which tick? Dermacenter. Lyme disease? Exodus tick. Yes, know that. I guess that's all what you need to know. Okay? Oh. Okay, so I guess we're done. I know you are. Who is exhausted? Yes. Yeah. Yes. 1 second. Thank you. Yeah. Okay. I can't. Yes. What? Bacterial genetics, conjugation, transformation, transduction. Know what it is. What is conjugation? Pili. How do you prevent conjugation? I have a joke. Okay, it's a bad one, but I guess you'll remember it. Okay, so you have two cells. And you add DNAs to the solution. These are two bacteria. Okay, you add DNAs to the solution. Which of the genetic process can you inhibit? Transformation, actually transformation, conjugation, or transduction? Which one? What is transformation? Transformation is the uptake of naked DNA. So you have DNA floating around, isn't it? You have DNA floating around here. One of these bacteria it gets absorbed. So which one can be prevented when there is DNAs? Transformation. Good. So if there is DNAs in the solution, transformation is inhibited because it's uptake of naked DNA. So when you add DNAs, this will get destroyed. These DNA can get destroyed. What can prevent conjugation? Conjugation is through, conjugation? For conjugation you need pili, isn't it? Okay, so you have the pili, which brings, what can prevent this? So, you know how we tell the students to remember? Okay, so what is this? Huh? It's a If you add a filter, okay. Now, when this question is asked, the students somehow never seem to get it. So, two bacteria that is separated by a filter, which can prevent, which of the process is prevented? Obviously, it's conjugation. Why? Because the filter acts like a, yeah, okay. So, that's the best way to remember, okay. So, you can prevent conjugation. Now, transduction is through phages. So, any bacteria that gets infected by a phage, that is transduction. So, DNase, because this is a concept that they keep asking in the exam. DNase prevents transformation, filter prevents conjugation, because for conjugation you need cell-to-cell contact. Anything that comes between the two cells can prevent conjugation. Transduction is through bacteriophages. That's all what you need to know. Okay? Okay. So we are done. And yes. Good luck. What I'll do is I'll just send this this document. I'll upload it on Blackboard. So if you need to refer, you can refer.